uninterrupted, continuous Cmes for the last 19 years. Wow. Keep blessing us, sir. Thank you very much. Over to Dr. M L Kalra, sir, to take the CME forward. देखो सर कौन सा माइक है कौन सा माइक
Dear friends, once again, I think I may be labeled as a chronic persistent chairperson because I have been chairing sessions quite frequently. I'm thankful to Physician Forum of India and Dr. Chauhan et al. To give me another chance to moderate a session of none other than my very good friend, Dr. Rajiv Agarwal, who is alumni of AIMS Delhi. He did MBBS, MD and DM, all from AIMS. And he was trained for international cardiology at Birmingham, USA. And he is a fellow of American College of Cardiology. His interest has been primarily in interventional cardiology and devices. So today's topic, actually I was a little confused how to introduce the topic. So it came to my mind like electrical disturbances in the brain, they call epilepsy, and similar epilepsy with the electrical disturbance in the heart, they call rhythm problem, we call it arrhythmia. So I may call it cardiac epilepsy arrhythmia. So he will be talking about rhythm abnormalities, its management, what are the current advances. There are medicines we have been knowing for quite some time, but there are newer advances and newer devices. He will also share with us some cases which are very interesting. So all yours, Dr. Rajiv Agarwal is not new to us. He has been attached to our group totally and partially, and he is one of the most gentle cardiologist friends. Thank you so much, sir. Please come.
Thank you, Dr. Kalra, for that kind introduction, and thank you to Physicians Forum of India, especially Dr. Chauhan and all the other luminaries, all old friends actually. I think I have come to this meeting after a long time, but I have been meeting all of you from time to time, and it is really a credit that I am part of CME number 908. So that sounds like really awesome. So therefore I approach this meeting with a little bit of preparation. This group knows everything. So you know, you have these weekly meetings. So I think most cardiology topics, because cardiologists are also, like sir said, he's chronic persistent chairman. So cardiologists are chronic persistent speakers, and most topics have been covered several times probably in this group. So the idea was to choose something which might be relevant to the practice of the physicians of the group. At the same time, something new and something in line with our sponsors of the evening Medtronic. So therefore, what I chose to talk about was the use of newer technology for arrhythmias and cardiac devices. Pacemaker, ICD, CRT, CRPD. I think all the physicians here would be having several patients who are on cardiac devices. Just right now, one physician was talking to the Medtronic person about the interrogation of a device. So everybody, I think, is well aware of the pacemaker and of other devices like ICD and CRT and CRTD. So pacemaker is used in patients primarily with slow heart rate or conduction block in order to ensure that the patient's electrical activity gets restored. The higher devices, the CRT, which is a biventricular pacemaker. Biventricular pacemaker confusingly has 3 leads. So normal pacemaker has either one lead, which is usually in the right ventricle, or 2 leads, which is right atrium and right ventricle. That's a pacemaker. And when you have 3 leads, so that there's a 3rd lead which is pacing the left ventricle, then it becomes a biventricular pacemaker, and that is a cardiac resynchronization device or CRT. If you add to that a defibrillator function, then it becomes a combo device, CRT-D, and you can have only defibrillator, that would be an ICD. So this is for, because I understand that it's a mixed audience, so there may be some people who are not that clued. But what I'm going to talk about is whether it is sufficient to just implant the device and tell the patient to contact Medtronic, find out the number, just like was being done here for interrogation of the device, or can we do something better? Can the patient have almost on-demand device interrogation, sitting at home, transmitting it to the doctor, leading to early detection? A couple of years ago, we faced the severe COVID pandemic all over the world, and at that time it was difficult even to venture out of the house. At those times, having remote monitoring of these devices was very, very useful, because these devices, they are machines, they can fail. The battery has a finite life. The battery will fail over a period of time, but there can be other causes of failure or malfunction of the device, and those need to be detected from time to time. Coming to the hospital is one way, and it allows us as physicians, cardiologists, to maintain the connect with the patient. But if you are able to do it remotely, have the data analyzed, and then the doctor and the patient get that data, that is very useful, and it is feasible even in our country. With the existing technology, all the manufacturers are providing this kind of thing. So this is what I wanted to talk about. But I will start with a recording from Apple Watch. So wearables also. So technology also includes wearables. So this is a patient of mine, actual patient, gentleman who stays hardly 2 kilometers away from Max Hospital. Well-to-do, upper middle class family. He had a heart attack, then he got a stent, and he was doing well, extremely apprehensive individual. So he has an Apple Watch, his son has an Apple Watch. And he's sitting at home, and he tells me that I have some uneasiness in my chest. So I said, oh, you have an Apple Watch? Or he actually told me I have an Apple Watch. I said, okay, you send me the ECG. Because the Apple Watch, especially of all these smartwatches, it has the function that it can record a single lead ECG, at least a 10-15 second strip, and by creating a right arm, left arm connection. So if the watch is placed on the left hand, so the back of the watch forms one electrode, and then you place your finger on the rotary knob of the watch. So that constitutes the other electrode, the right arm electrode. So right arm to left arm connection is formed. ECG is, after all, assessment of the current which is going from one part of the body to the other part of the body. So lead 1 is like right arm to left arm, and lead 2 will be right arm to the leg. So the Apple Watch can give you a rhythm strip, and a 15-second strip, it is recorded in the Apple Watch, and it can be transmitted. It can be transmitted straight away. So this guy sent me this strip, and first I didn't believe it. But he said, no, this is how it was, and I felt a little uneasy. But I said, you're talking, you're absolutely okay. So then he says, I got my son's Apple Watch also. उसमें भी मैंने किया, and I'm getting the same ECG. I was still very skeptical that this may be some technical fault because the patient is nicely talking to me. And he is not even a young, 25-year-old guy who can have a ventricular tachycardia and be absolutely asymptomatic. This is a post-MI patient who has an ejection fraction of 45%. With this ECG, I would have expected that this would be a precursor to sudden death. Fortunately, all that didn't happen. He actually came to us after half an hour. When he came, he was back to normal sinus rhythm. And he was very anxious. He self-discharged, although he said you can't go home and so on and so forth. And we'll keep you for observation and implant at ICU. Anyway, next day, he was back. He came again with this ECG. Sorry, it's a little dark. But this is again showing sustained monomorphic ventricular tachycardia. Settled with IV cordon and now was willing for an ICD implant. So with this kind of recurrent arrhythmia, not only do we consider implantable cardioverter defibrillator, so that will constantly be monitoring the beat. If this kind of ECG is there, then it will give a shock to correct the arrhythmia, and you will consider 3D mapping or RF ablation data. But fortunately now this event is 1.5 years old. And he has not had any further event. So what exactly happened in that week or so when he got 2 or 3 episodes, we're not clear. But we have kept him on cordon and some beta blockers, and he has not needed radio frequency ablation. Although in many such cases, there are patients who had, even after an ICD, they've had several episodes of VT requiring shocks. And so then we've done RF ablation with 3D mapping and we have corrected it. But this patient, so this was the triumph of the wearable technology. So remote monitoring, wearable technology. If you can transmit your ECG, there are other things apart from Apple Watch which can do this at home. Trans-telephonic ECG, you need a separate instrument. There is something called Alive or Bataiye sir.
So this was more than 30 seconds, Dr. Rajiv?
Yeah, sustained.
So sustained VT.
Sustained VT, but so not every VT. So you cannot diagnose VT by only the patient's hemodynamic compromise. VT can also be hemodynamically stable and SVT can be unstable. However, patient who is 64 years old with post-MI situation, ejection fraction 45%, mostly I would expect this ECG to lead to patient crashing. But he did not. And this is a hefty guy. He's what, 80-85 kg, obese, etc., etc. But so God is great.
We'll talk about this later, after your end of the talk.
Therefore, it is very variable that what VT will be tolerated. So, as you said, sustained VT is what is not tolerated and needs to be immediately cardioverted, etc., or it lasts more than 30 seconds. And this is sustained and it is also monomorphic, suggesting that this is likely to be a scar VT. You can have VT which is polymorphic, which is often drug-induced. This was not that kind. This was sustained monomorphic scar VT in a patient who is post-MI, picked up by Apple Watch. So this was an interesting case. And so we picked it up using modern technology. So there are many things. The wristwatch, which we talked about, even smartphone can at least give you heart rate. It can give you heart rate. There are patches which we'll talk about, which are now giving a tough competition to the Holter monitor, the good old Holter monitor. You apply electrodes, you give the patient a pager kind of device for 24 hours. But instead of that, you can give the patient a patch which will record the complete ECG for 3 days or 7 days, and that is far better than doing a Holter. Because it is lasting 3 to 7 days, it will have a higher yield in picking up arrhythmia. And also, the quality of the recording is also better. And now the latest thing is the ring. So various ring devices, Oura ring, etc., etc. Those are coming in. So technology is proceeding apace. So we do not tell our patients to buy an Apple Watch, but if he does have an Apple Watch, or I see one, I say, have you activated the heart function on this? Can you send me an ECG if it is required? And in some of our techno-savvy and relatively younger patients, this has been really useful. So that is one thing I wanted to tell you. The second was, so I'm not giving a comprehensive view, I'm only talking about what is practical. So one is that is the patient. If the patient has a wearable device which has this function, most smart watches will tell you about the heart rate. And if there is a sudden jump in heart rate or irregularity, they might even alert you that it is possible that the patient has atrial fibrillation. To my knowledge, most other watches will not record the ECG like the Apple Watch, but probably that is coming or has already come. So we can transmit the ECG to the doctor, save it and transmit it through the Apple Watch. Rather than Holter, which is a 24-hour recording, in patients who have undiagnosed arrhythmia or loss of consciousness, you suspect that the patient may be having a heart block, or the patient has had a stroke of undetermined origin, so atrial fibrillation leading to cardioembolic has to be ruled out. Instead of a Holter, you can do a patch recording, extended monitoring patches. So this is a patch which has a battery pack in it. It records the ECG for either 3 days or 7 days. You can have a 3-day patch or a 7-day patch. So a complete recording is done in this, and then this will communicate with the patient's mobile phone and then on to the central server. So it does not need to communicate in real time with the mobile phone, but the data dump is done through the mobile phone and then to the central server, and this gives a quality of recording which is superior to the Holter recording. Better quality recording, longer duration, higher yield because longer duration and also better quality, reasonable cost. It is slightly more expensive than the Holter, not unduly so. Convenience of home application, and in 3 to 7 days it is shower proof also, so the patient can even have a shower. So it is waterproof, the patient can even go and have a shower. And so we are able to go to the patient's home and implant it anywhere in NCR, and they give us good reports. It comes on the email. If there are any events, then they even alert us. So there are many vendors. The one that we are dealing with, I told them to give me some slides, and this is it. And so nowadays, I think I try to encourage my patients, rather than a Holter, you get a monitoring patch, and 3 to 7 day patch is good. So this was one of their, when they collected their data, they had done 1,22,000 procedures. I think now in October, they are up to 1,50,000 procedures and have detected now close to 1 lakh of events. So this figure has gone up. So 1,50,000 procedures done, 1 lakh events detected. Of the events detected, around 30% of the events detected were detected beyond 24 hours. So if you had done a 24-hour Holter, you would have missed 30% of the events. So the longer the duration of the recording, the better will be the diagnostic yield, be it for atrial fibrillation or supraventricular tachycardia or ventricular tachycardia or a significant pause. Significant pause means that the patient has slow heart rate and might need a pacemaker. Even if you have a negative correlation that the patient's rhythm was being recorded, the patient had an event and the heart rate was not normal, even that is very useful. That look, your symptoms were not due to the arrhythmia. So this will be better than doing the Holter. And all of these were detected and full disclosure, etc., etc. So there is full disclosure. It's not that it is applying some algorithm. There is the entire data dump is transmitted to the central server, and we rely on them to have taken out the relevant scripts to send to us, because as a doctor I do not look at 3 days of recording all the time, but I hope and trust that the central team with some algorithms is looking at it, and if required then you can go to any specific time and look at the ECG at that particular time. And here you can see polymorphic non-sustained ventricular tachycardia in this patient, and you can pull up the full disclosure from any period of time. Even the P waves are seen much better. So some of these studies are showing actually that even in a 24-hour recording, the quality of this patch ECG is better than the ECG which you get by the conventional Holter, and then some other studies also. So then there are many other technologies. Abroad this patch is known as the Zeo patch, whatever it's called. And then there are other technologies, and this is an evolving field. But wearable watches and the patch are things which are available to us. So in Delhi today, I think we should be aware of it and we should be able to use it. Some of our patients also, they go abroad, they get this handheld ECG Alive Core. So Alive Core is like, looks like a flat chip, and you can hold it with both the fingers, the thumb and forefinger of both the hands. So that again forms the electrode right arm to left arm, and you can get a single lead ECG from that. Again, you can transmit it. If you put the back of that chip on your knee, then you get a third electrode from the leg, and so then you get the complete frontal triangle. So you can actually get a 6-lead ECG, because the 6-lead ECG is based on right arm, left arm, and the leg. So even when we record, for those of us in whose clinic ECGs are recorded, we know one electrode is put on the right arm, one on the left arm, one on the leg, and that gives you the frontal plane ECGs 1, 2, 3, RLF. RLF are derived from it actually. And then you have the chest leads which are separate, so that gives you 12 leads. So you don't get the complete 12 lead, but you can get a 6-lead ECG out of the Alive Core cardiac device, KARDIA. So that is also something which can be done and might be available from time to time. So then, remote monitoring of devices. You have given your patient an expensive device. Even the pacemaker will cost upwards of 2 lakhs of rupees by and large, and ICD, CRT will cost double of that. Now, to get the maximum benefit out of it, the device must be constantly monitored, just like you get your car serviced and so on and so forth. And if you do remote monitoring, you will have multiple benefits. Some of them are very obvious. You don't have to move out of your house, and you get a reliable reading. Any machinery is liable to failure. Each component of the pacing device or ICD is liable to failure, including the pulse generator, the leads, the connection. Then there can be noise, myopotential inhibition, arrhythmias can occur. So all of this would be detected when you come to the hospital and interrogation is done. Like Rupali is told, send the technologist home and he will interrogate the device. Sure, it can be checked, but it can be checked sitting at home, and a dangerous event or problem can be alerted to the doctor as well as to the patient. So the clinical benefits of remote monitoring, actually when they have done these studies, some of these studies have shown a lower risk of all-cause mortality, 50% lower risk of all-cause mortality, because it reduces inappropriate shocks. Many times the ICD will give inappropriate shocks because of various things, especially T-wave oversensing or atrial fibrillation with fast ventricular rate or other misdiagnoses. So you don't want to get a shock, you are sitting comfortably and suddenly you get a shock. And later on you find there was actually only a fast rate because you got excited, you were watching the match, somebody was watching the match, किसी ने छक्का मार दिया and your heart rate went up and the machine detects it as a VT and gives you a shock, so nobody wants that. and that kind of troubleshooting can be done by remote monitoring, reduction in all-cause mortality, reduction in emergency visits, and hospitalization for AF or stroke. All of this can be done. So much so that since 2015, the Heart Rhythm Society strongly recommends remote monitoring as a class 1A recommendation. That all patients who have a cardiac implantable device should be offered remote monitoring as part of the standard follow-up management strategy. Now this will certainly add about $1 lakh to the cost of the patient. So obviously money is at a premium, but there is a benefit at least in the affording patient. So firstly, what does it look like? Actually, you can, each manufacturer, this is from Biotronic, this is Medtronic, this is Boston, this is St. Jude. All of these, they will have, apart from the implanted pacemaker or device, they will have a separate unit which will communicate with the device, and then that will transmit wirelessly either through the mobile phone or otherwise to the central server, where a team will be looking at the data and will alert the patient and the doctor if there is a significant event. Nowadays, there is smartphone technology where you don't even need this separate unit. If the device is Bluetooth enabled, then the device which is implanted inside the body can communicate with your mobile phone. You don't need a separate unit, and it can do this remote monitoring completely seamlessly. First, one of my such patients, so elderly gentleman, 80-year-old, son is sitting in Thailand, and he says, I want the best ICD. So he said, we'll give you the Bluetooth enabled ICD. So one fine day, the Bluetooth is off in the mobile phone, and I'm getting a call from Bangkok, father, the device failed over. And this is the middle of the night. I said nothing is happening. Patient is absolutely comfortable. Next morning it was found that somebody had inadvertently turned off the Bluetooth. And so you need to be able to utilize the technology properly. But if you use it properly, then it will give you definite benefits. So I said that it is a class 1A recommendation. And what it does is, so there are multiple studies, preferred study, Compass trial, there is a retrospective analysis by Verma and Mittal, although these are Indian names, but mostly these studies are from abroad, and then retrospective analysis. So all of these shows that you will detect events on average 2 months earlier than you would detect if you were coming only to the hospital to get your device checked. Fewer hospitalization for atrial fibrillation and strokes in the remote monitoring group, improved survival across all device types, and survival was significantly better with a higher percentage of time in remote monitoring versus no time in remote monitoring. Reduced hospitalization, etc. So there is a lot of data to support this. So I showed this reduction in mortality, etc. and all devices. So this is it. And patient adherence matters, and you can have it without any extra device. This is the Medtronic device which will communicate with the mobile phone. This is the mobile phone with which the device will be communicating, and it will take the data from time to time from the pacemaker or ICD or CRT and transmit it to the central server. These interrogations are also kept under check in order not to consume too much battery, but it does not reduce the longevity of the device too much, maybe by a few months only. So then this can be very useful and it will give multiple benefits. Still, there are many reasons why it is not utilized abroad. These are the numbers: 47%, 47%, 84% across different manufacturers of all devices. This is the proportion of patients who will have remote monitoring. In India, I would say, honestly speaking, this should be less than 5%. Much of the reason is also that either the cardiologist or the physician are quite skeptical that this is going to be useful. It will add about $1 lakh to the cost, but in some cases it will really benefit the patient by early detection of event. So if the patient's lead impedance is progressively rising, you know that this lead might fail, or they may be developing noise, so it will lead to inappropriate shock, etc. So you can call the patient and you can confirm the findings, you can replace it. So there is a chance to improve the management of at least our affording patients, or patients, many patients come from remote areas, even neighboring countries, where the monitoring might not be available. So we can give these devices to them, because this would be worldwide and we will get the information, and it will lead to a better patient connect also. If the patient knows that you are able to access the patient's data, then it leads to better patient connect and patient adherence. So this is it. Patients who are close to end of battery life, frequent remote monitoring allows them to postpone replacement till it is absolutely needed. Otherwise, you might end up doing the replacement 1 year before time, because you know the patient is dependent on the device. You don't want to take a chance. He's coming from Pithoragarh, so you say lagwa lo, lagwa lo. Otherwise, you can for outstation patients, you can maximize the time that this is there. Early detection of frequent atrial high rate episodes. Atrial high rate episodes are usually atrial fibrillation. If they cross a certain threshold, then this atrial fibrillation may even lead to stroke. Admittedly, this is a lower frequency than in clinical atrial fibrillation, but it is there. And some of these patients can have stroke. Some of these patients need anticoagulation. So these the remote monitoring will detect these atrial high rate episodes, can lead to anticoagulation and other therapies for AF. Old leads that are prone to malfunction. RV lead noise can lead to inappropriate shock. Remote monitoring allows early detection and replacement in ICD patients. This has happened in at least a couple of our patients, that they have had RV lead noise and we have replaced the patient's lead. One of my patients, post-CRTD, patient was having recurrent syncope, and then we found that this is because there is RV lead noise leading to myopotential inhibition, because this noise is detected as electrical activity and the pacemaker gets inhibited. So this was leading to recurrent syncope. Old RV lead with noise leading to myopotential inhibition. And we converted the device to asynchronous mode to maintain pacing despite RV lead noise. This patient did not have remote monitoring, which would have been very helpful in preventing these dangerous syncope episodes. So there is this particular study amongst many studies. The recent study, which was last year published in NEJM, looking at atrial high rate episodes, device detected. So if you have atrial high rate episodes, 6 minutes to 24 hours, meaning atrial fibrillation episodes lasting from 6 minutes to 24 hours. If the patient has high CHA2DS score, then this patient deserves anticoagulation. That is the summary of this long slide. There is a role even in detection of heart failure and monitoring of heart failure and looking at early worsening. So there is something called opti-valve function, which looks at thoracic impedance, the amount of fluid in the chest. If there is more fluid in the chest, then the thoracic impedance goes up. So this tells you that fluid is accumulating and you better increase the diuretic. Patient activity, if it goes down, if the patient has frequent atrial fibrillation, if the patient has arrhythmias, if his ventricular rate is going up, all of these can indicate worsening in patients with heart failure. So multi-parametric monitoring in heart failure can be done by the remote monitoring device. So this is, I think this is hardly visible, but it can detect these events early. So remote monitoring, so this is that was the 2015 recommendation. This is my last slide on this. 2015 recommendation, and now in 2023 the latest Heart Rhythm Society recommendation says that for patients with implantable devices, Remote monitoring is the standard of care. It is class 1A recommendation, reduces the number of healthcare visits, increases follow-up adherence and patient retention, effective and safe surveillance of device function, early detection of arrhythmia, reduces inappropriate shocks, potential benefit. So the prevention of stroke by detecting atrial high rate episodes is considered still to be a potential benefit, and the benefit in heart failure is also considered to be a potential benefit, not fully established. But the earlier ones are fully established, and we should use them more and more in these various ways. You can program it to give you alerts for important events. So this is the end of this, and if there is still an attention span left, I wanted to show one tally case and one micro clip case.
Sure, sir, please.
Please go ahead. Please go ahead.
Sir, all yours.
So I'll just show those two, and we'll be done with this. So there are several cases in this, but I'll show the first 2 or 3 cases only. So, because I need to tell you that we are doing all these procedures and encourage you to send them to us. So TAVI in an old patient with severe aortic stenosis and multiple comorbidities. So TAVI, I think you have probably heard several talks on this, and elderly patients with calcific aortic stenosis are often high risk because of multiple reasons, not just the heart disease, but associated other diseases, lung disease, kidney disease, maybe cancer survivor, even coronary stents, etc., etc. So many of these patients are inoperable or at least high risk for operation, and so a percutaneous replacement of the aortic valve is very, very useful in these patients, and now it is becoming more and more the standard of care. Earlier we started with inoperable patients and high risk patients and moved to moderate risk patients. Now, although still controversial, even low risk patients, we can do a TAVI procedure. So even patients in the 50s are saying, I don't want my chest opened, and you do a TAVI procedure. So there are some downsides of doing that. Now you implant a biological valve in a 50-year-old patient. The average life of that biological valve is only 15 years. So now this guy who is going to survive probably 80 years, till 80 years of age, is likely to need a replacement. So therefore that risk benefit has to be looked at, and other things. Surgical AVR in younger patients has very, very low mortality. So definitely in moderate risk and high risk and inoperable patients, it is TAVI all the way, and we are able to give almost, well, nothing is 100%, but almost 100% results in that group and palliate the patient. But in younger patients, one has to individualize. Well, this was a young 81-year-old patient with multiple comorbidities, hypertension, diabetes, etc., history of LVF, severe calcific AS. His calculated risk for surgery was high, and we did this procedure with the Indian TAVI valve. So this is a big achievement of Make in India, that you have the international standard valve manufactured completely in India. And most of the success of the procedure is related to the pre-procedure planning, which includes a very, very detailed CT angiography, which looks at the entire aorta down to the femoral artery axis, also at the anatomy of the valve, the left ventricular outflow tract, the sinotubular junction, the height of the coronary arteries, etc., etc. And with a special software, all these measurements are taken, and the measurements have to fall within the range. The coronary height should be sufficient. The sinotubular junction, that is the just where the sinuses end, this should be wide enough so that it does not cause stenosis. The left ventricular outflow tract should also not be small. So all of that, then there will be special considerations in those cases, but otherwise all of those need to be seen. and then you have cross section, so we need not go into it. And then the access, because this is a very big access, you will have an access which is around 3 times the size of the puncture that you make for coronary angioplasty. So you will have around a 14 French hole, whereas in angioplasty we use a 6 French hole. 6 French means 2 millimeters, 14 French means 5.5 millimeters hole is there. So you then actually image the femoral artery over the femoral head and then puncture right under vision. So that is what we do, and then we will place a Python catheter, which is a dilatable catheter, into the femoral artery and up the aorta, and pass the balloon mounted tissue valve up the aorta in order to reach the aortic valve. So you have to stay away from any aortic atheromas, etc. You have a pigtail for guiding. You have a pacemaker for very rapid ventricular pacing in order to bring the heart to a standstill. And then you have passed this wire, which is a very stiff wire with a coiled tip so that it does not injure the ventricle. And over this then the catheter is passed here. The balloon with the valve mounted on it is passed across the aorta into the position. So this is the valve which is with calcium. So it is passed there, you position it, you give rapid ventricular pacing to make the heart stand still, you deploy the valve. So here, and the valve is deployed in the next image. And so it's all over within a few seconds. So once all the planning is done, the procedure is actually short. It is done under general anesthesia. We do have surgeons standby. Now not so much. Earlier we used to have the surgeon in the room. Nowadays they have lost interest. They say, "Ye to tum hamara kaam kaat rahe ho," so they don't come. But we are able to do these procedures because we know that the surgeon is there to have our back. Fortunately, with proper precautions, we hardly ever require the surgery. There is a risk of stroke. In some cases where there is associated carotid artery disease, you might need cerebral protection also. Some cases where there may be distorted anatomy, you might need various maneuvers in order to ensure this. Sometimes if the coronary height is low, then you might need to pre-place a stent in the coronary artery in order to protect the coronary artery when you do this procedure. So there are various things, but this is a standard procedure. We no longer use a surgical cut down. We close it with per-close sutures in the cath lab, reduces complications, improves patient comfort, and so this has become standard of care. Landmark trial, which was done in Europe with this MyValve, 768 patients, 31 sites, showed that this was as good as any other valve. So this is a TAVI procedure which I think we are doing several in our center every month over various cardiologists, including myself. So we would like to see these cases. Then there is transmitral valve replacement. Now, if a patient has a degenerated bioprosthetic valve, so bioprosthetic valve is often put in the mitral position, even in the aortic position, the idea being that the patient will avoid anticoagulation with acetone. This may be especially important in patients in the active reproductive age group, and even otherwise avoiding anticoagulation is a useful thing. Problem is that even the best of the biological valves, the average life expectancy is 15 years, and there is sudden worsening, and sometimes we have lost patients because their valve degenerated. So now you have to replace it. Once a thoracotomy is done, a second thoracotomy carries 3 to 4 times the risk. And so if you can do this procedure also by the percutaneous route, it is obviously going to be better. So here you use the same valve, you will invert it so that it is pointing in the other direction. You go transvenous through the inferior vena cava, right atrium, across the septum, into the left atrium and then down into the mitral valve. And then you deploy the valve with almost the same technique. Again, you do a detailed CT, you will visualize how the valve will be placed inside the mitral valve, and will it obstruct the left ventricular outflow tract, and then you do a transseptal puncture in a precise way. In this case, we needed to do RF ablation in order to get a low and posterior puncture so that the catheter will fall directly towards the mitral valve. And then this wire is passed. So this is the delivery Agilis catheter. The pigtail is being passed and it is going directly into the left ventricle. This is all from the venous route, RA, LA, LV. And then there is the dilatation of the septum, and then the placement of the mitral valve, the same valve in a reverse direction, and we get a good result. So several such cases also we have done, and with touchwood, good results. Functional mitral regurgitation or secondary mitral regurgitation, this may be because in heart failure patients the mitral annulus has dilated, so the leaflets are not coapting, or there may be papillary muscle dysfunction. So in these cases who are going to be surgically high risk, again by going by the transvenous transseptal route, if you can reduce the mitral valve orifice, you will get a reduction of the mitral regurgitation. So the mitra clip is this kind of device which will actually hold the two leaflets of the mitral valve and bring them together, and so the opening of the mitral valve is reduced, the mitral regurgitation is reduced. Again costs an arm and a leg, but it helps in patients who are not able to get surgery and will be. So TAVI cost has come down. This one is still double the cost of TAVI, but still there are patients who afford even a left ventricular assist device. So this is how it looks like. The two clips are open here. This is done with transesophageal echo, and the two clips are open here. And again, it has gone transvenously across the septum. Here it is opened up in the mitral valve orifice and will hold the two leaflets. So this is the mitra clip in position, and it has reduced the mitral regurgitation. So that's it. I think I have other cases, but these are the three structural heart cases. I think the angioplasty we all.
Lights, please. Dear friends, you must have noticed Dr. Rajiv has very cleverly and very humbly given two talks. Actually, he was two in one. One was dedicated to Medtronics, and the other was his skills about the interventions he is doing, like TAVI and mitra and many others. And it's one of the best hands I have ever seen. His last part was very impressive. And I think case selection is the main thing that matters. And sir, सब जानते हैं सर, मैं ज़्यादा टाइम नहीं लेता हूँ. Just I will set the ball rolling. Diabetologist and cardiologist, they are rather competing. Diabetologist ले आए एक patch CG continuous glucose monitoring के लिए, and then you have brought a patch for continuous heart monitoring. So yeah, going hand in hand. तो एक पैच के बाद दूसरा पैच लगाते हैं तो will it compete with ELR, which was recording for more than 2 weeks and all that, or it is?
This is ELR. So when we talk of ELR, actually ELR is a wrong term now, because it's not a loop recorder which is recording and it is deleting the data. What these patches do, they will record the data for the given time. So there can be a patch for 2 weeks also, and then it will record all that data, transmit it centrally, it gets digested and you get the report. The event recorder or the loop recorder which was there earlier, I think it is more or less obsolete. Implantable loop recorder is there which does that kind of recording over 1.5 years. But that is also in India at least it has not caught on. I think I have implanted it in less than the number of fingers on my hand. But yes, it is very useful. You can place it in an outpatient setting. It's a chip-like device, small incision, cut से यहाँ लगा दिया, and then you if the patient has a syncope and that device does not show an arrhythmia, you can say that this was non-cardiac, or it will detect that arrhythmia. In 1.5 years, you are likely to get me there. But implantable loop recorder has not caught on because the cost-benefit ratio has not been that great on it.
It already just came to my mind that it is externally or loop recorded.
Yes.
So can it be hacked? Because we are hacking mobiles. आपने ये नंबर दबा दिया, ये नंबर दबा दिया तो आपका मोबाइल हैक हो गया। मोबाइल में भी आपको वहाँ से सर्विस दे रहे हैं, आपको मोबाइल बंद हो जाएगा नहीं तो ये दबा दो। So like that.
So theoretically yes. I think if you are TV addict तो ऐसे plots भी serials में भी आए हैं. The President of the United States sitting in his office and somebody hacked his ICD and so all that. But I think we can leave this to the suspense factors. I think for you and me, nobody is going to do a James Bond answer.
Right, sir. So just one more. You showed some new advances like going.
और Israelis ने pager पे bomb लगा दिया. So all that can be done, but I think that is.
Smart watches was one.
Yes.
Another was eyeglasses, and there was some necklaces. So necklaces, is it for females only, or you and me also will be wearing that?
Sir, just it can be a male adornment also. But Ura ring is I think the future. If the day that we are able to give accurate blood pressure, this ring will be very useful. Abhi to it is mostly giving you your sleep time and sleep quality, maybe some pulse rate, activity tracking. तो वो तो आप mobile phone से भी कर सकते हैं. So I think right now there is more hype about the ring, but at least so I don't say that every cardiac patient should buy a watch, but if you do have a watch, then you can have this kind of excellent recording out of the.
My last question is rhythm and rates. They are very well documented on these smart watches and all that.
Yes.
Do they tell us about impending MI or some ST segment changes also?
Sir, impending MI, if you have sudden change in rate, then you can be concerned that is there an impending MI, but not directly. ST segment, it's a work in progress. It has not happened yet. You can record the ECG, transmit the ECG, and Dr. Tulsi will see the ECG and he will say कि हाँ भाई तुम आ जाओ, तुम्हें heart attack हो सकता है.
Dr. Chauhan is very keen to ask questions.
No, I just wanted to ask you, sir, this remote sensing thing.
Yes.
Once you sense it, sir, can you remotely correct it?
That again we do not. It might probably be in the realm of possibility, but then it comes to the interference thing, so that is not being done. But once you diagnose it remotely, then you get out alerts. The patient is told to immediately come. The patient will be checked in the hospital and appropriate action will be taken. Sometimes it just needs some additional beta blockers, etc. Or if there is a chance of atrial fibrillation, then add anticoagulation. Sometimes it might need a lead replacement, etc. etc. So all options will be there. But remotely correcting, we are not yet doing.
Suppose you have a patient you showed on the phone, on the Apple Watch, the VTech. Both son and father recorded. Suppose you had this patient in Panipat. How would you have managed, sir?
Panipat, I would have told him to go to the nearest hospital and get admitted there, get his VT, whatever clinical evaluation and management is to be done. For that matter, patient across the city, पंजाबी बाग से मुझे फोन आता है, patient says कि डॉक्टर साहब हमने तो आपसे इलाज कराना है, मुझे हार्ट अटैक हो गया, मैं कहता हूँ तुम जिस हॉस्पिटल में हो वहीं पे तुम कराओ, within 1 hour your vessel must be opened up. So we have a responsibility not to hold on to the patient but get the patient the best care. So certainly patient is in Panipat, I would tell him to go to the nearest hospital up to tier 2, tier 3 cities, all have reasonably good cardiac care. And then if the doctor there is willing to talk to us, we can communicate. Telemedicine has grown by leaps and bounds, and we can take care of the patient. But time is of the essence in the heart.
Sir, one sensitive question, and I hope you will not mind it. Rhythm can be disturbed any time. It can happen 2 a.m., 3 a.m.
Yes.
I have seen some of the cardiologists they switch off their phone in the night. Do you have a support system, a support staff, where your patient can send those rhythms to somebody who you have, said that if my phone is not reachable, I can send this rhythm to this guy. So do you have a support staff? Do you have a team? Because I think you need to work as a team.
So this is the importance of working in an institution. We have a team. I can go to, I can be on holiday. So that doesn't mean that if my patient gets a heart attack, he will not be attended to. I am sitting here in the CME, it has happened with me. I am sitting in the CME, I get a message that my patient is having a heart attack. So I have other colleagues who will take care of it. In the middle of the night, well, I don't switch off my phone, some people do. But we always have a doctor on duty, the cardiology doctor, the ECG, etc. can be transmitted to them. Of course, mostly our answer is, please come. And if you can't come, we'll send you the ambulance. And you come. So this is the advantage of having a team, and we have team members at senior level, we have team members at junior level who can be directed. So when you get my support or any of my other colleagues, then you get the support of the entire institution. So that so the cardiac surgery is also tapped through us. And arrhythmia, special arrhythmia services will also be tapped to us, LVAD will be tapped to us, so all that is there.
Sir, everything comes with a cost. And we are a very price sensitive society.
Yes.
What is the cost of this remote sensing ability that you are offering?
So I think the Medtronic people will better answer that, but I said in my talk that approximately it will add about 1 lakh to the cost. So most patients with pacemaker in our setting will not get it, but the patient who is spending 7-8 lakhs on a high-end ICD or CRTD, he wants the best, he can very well spend that 1 lakh more. And in the higher-end devices, because this is the patient with more advanced disease, so it is especially useful in that. Because of course battery issues are there with everything, but if there is any lead malfunction, it can lead to loss of pacing, or it could even lead to inappropriate shocks. And so all this monitoring can be done. And then heart failure monitoring by the thoracic impedance and other things in the CRTD device. The CRTD patient is a heart failure patient. So such patients, if you can see that look, his parameters are worsening, then you can call in, you can even tell him to increase his Ditor or Lasix, etc. We have done it on a few occasions, and some studies have shown that that actually reduces events. So
Sir,
all that can be done.
I want to ask you, with so much of implosion, if I can put it, of TAVI, are we going to have an epidemic of degenerated valves 10 years down the line? Your honest answer to that.
So this is true that if you now extend TAVI to the 50-year-old who says as a lifestyle choice, 15 lakhs, 18 lakhs I can spend, लेकिन चेस्ट नहीं खुलवाऊंगा, और वो 50 साल का है, 65 साल की एज पे उसे रिपीट करना पड़ेगा, वो कहेगा उस समय डॉक्टर को सू करेगा कि तुमने मुझे ठीक से उस समय क्यों नहीं बताया. So that is an issue. But this 70-75 year age patient, this is a very clear-cut indication. Average lifespan 85-90, so it will last him his lifetime. He is anyway going to be high risk and for a routine surgical procedure. So those cases in our setting, I would say, so I do not do the partner 3 type of patient, which is the low risk patient. So evolute low risk and partner 3 These are the two studies, latest studies, which have looked at low-risk patients. I would still urge caution in that. Our surgical colleagues also tell us that sometimes TAVI has to be explanted and this creates a big mess. But in the moderate to high-risk patient, so CGHS also says you calculate the STS risk score, Society of Thoracic Surgery risk score for likely complications with surgical AVR. This risk score should be at least 5% risk before you say that in order to reduce that risk, I want to do a TAVI. So I think what I would say is that in our setting, stay with the moderate and high risk patients. We have the largest population in the world, we have no shortage of patients. So leave the income tax commissioner who says मैं 50 साल की age पे, and ये हुआ है. I mean, some of the early cases done in Vedanta, the income tax commissioner पहुंचा, उसने कहा मुझे तो अपनी छाती नहीं खुलवानी, तो उसने टैली करवा लिया. अब वो 15 साल पहले तो उनके सब फाइलें खोलेगा कि मेरा वैल डीजेनरेट हो गया, अब तुमने पहले टैली कर दिया, अच्छा धंधा बना दिया है, अब तुम उसमें टैली के अंदर फिर से टैली डालोगे. Yes, it is possible, but everything has a cost and it has complications. So we should be aggressive, but also mindful of the complications and keep full disclosure. And I think we have to record, because when we tell the patient something, he will not hear. He will only hear what he wants to hear. Later on, all allegations come. आपके Facebook पे डाल देंगे ये किया वो किया. So we have to be honest and also tell them about it. So the younger patient, we have to know that if you do a TAVI, then 15 years down the line you may have to do a redo TAVI. That is possible. We have done it, TAVI and TAVI. Or so if the patient has a previous mechanical valve, then you can't have TAVI. But if the patient has a previous biological valve, you can do a TAVI in that. We've done it because that valve can be plastered.
Sir, just for the benefit of all who have chosen to stay, all my dear delegates, very, very keen to learn from you. One of the advantages of the bioprosthetic valve that is said is that they do not need any anticoagulation, and at times they do not even need a dual antiplatelet cover. Sir, your take on that, and what kind of an antiplatelet cover or a blood thinner in our language that you give after a prosthetic valve, bioprosthetic valve?
3 months you give anticoagulation. Initial 3 months you give anticoagulation to the patient, and after that you need to keep the patient only on aspirin. If the patient has atrial fibrillation, then he still needs anticoagulation long term. So in atrial fibrillation, you would still need to give anticoagulation because of atrial fibrillation. But otherwise, yes, you don't need long-term anticoagulation.
Sir, my two last questions. You said the cost is now coming down, a lot of competition on the valve front,
yes.
And a lot of companies competing.
So 25 lakh से 15 lakh आ गया.
Sir, what is the minimum cost of TAVI? If we bring a patient to you and say, sir, बहुत middle class है, out of pocket pay करेगा. What is the minimum cost of TAVI?
If the Indian valve is cheaper, CGHS, since it has approved, so it has brought the price down. So the multinational companies are also providing at that price. तो फिर भी जो 25 लाख का procedure था, that has come down to 15, 16, 17 lakh, something like that.
Sir, mitral clip. The cost of mitral clip. Sir, बताइए sir, please. Around 20 lakhs. And do we need anticoagulation with mitral clip or no? We don't need any anticoagulation with mitral clip.
With initial 3 months, you do need anticoagulation.
Same as the valve. Yes. Same as the valve. And after that, sir?
After that, it will be individualized. Most of these patients will be having atrial fibrillation anyway, so they will need anticoagulation. So that is not the bigger issue. If you prolong the patient's life, that is.
Thank you. Before I come to Dr. Tulsi, any questions? Sir, Dr. Narendra Vadera, sir, you say my dear sir.
So you talked about Holter monitoring versus UOCAS for a longer time. Here we have Holter monitoring for 24 hours. In the West we have UOCAS up to 30 days. We talked about diagnostic yield. How much is good enough? How many days is good enough to have a good diagnostic yield? 3, 7, 14, 30.
So the longer you do, the more cumbersome it is, the more costly it is, but the yield is also better. So we have tables that the ECG is only 15 seconds, so it will give you 0.2%. Then you can do a loop 24-hour holter, you can do a loop recorder, you can do this geo patch up to 30 days, of course. Then you have an implantable loop recorder. Then in some patients you do EP study. So nothing is 100%. But
how many days you are doing in India and what is the cost?
Sir, I think we are with this vendor. तो 7 days तक का मैंने देखा है. Whether they are able to offer it for 2 weeks or 4 weeks, I don't know. But generally patients scrib at even the 7 days. So 3 days the most popular. 3 days will cost around 5,000, 7 days cost around 10,000, and उतना हम कर ले, उतना हम कर.
Dr. Amish Vora, our oncologist friend. Oncology. He is DM oncology trained in Dhaka.
Okay.
Trained abroad and has his own center in Hoskas. Wonderful center. Very people friendly center and very doctor friendly center. He has a question.
So about the remote monitoring.
Yes.
Recently, one of the patients on chemotherapy had frequent atrial fibrillation.
Okay.
Just couldn't find the reason. Finally, the cardiologist said it can be zolpidem which patient was taking.
Zolpidem?
And we stopped zolpidem. There are reports of causing some atrial fibrillation. हर drug का आपको मिल जाएगा.
हाँ.
My question is that does the remote monitoring help in finding out the drug-induced arrhythmia based on the type of drug taken and your monitoring? Does it cause or it is too far?
डेटा आपको मिल जाएगा. Now you have to do the detective work yourself कि इसको arrhythmia हुआ, this time हुआ, was there a temporal relationship to that? All that heavy lifting has to be done after that. But this will give you full disclosure of the data if you were so minded. It will tell you all the trends. You can generate all graphs. You can sit with the manufacturer. He is sending you the full disclosure on demand to the doctor. The doctor can sit with it. We rarely do. We generally depend on the algorithm-based report that he is sending us. But if required, we can sit down with it and generate all that. But so sure, now you picked up a correlation with zolpidem, true or false, I don't know, but
we don't know, sir.
Sure.
Sir, the number needed to treat or number needed to save life.
Yes.
Between the standard symptomatic arrhythmia diagnosed in in-office ECG versus Holter versus patch. What is the, you showed 27% reduction in the mortality in one of the slides. Was it relative reduction?
That was with remote monitoring of
No, was it relative or was it absolute, sir?
No. That was with, that is relative. So that really magnifies the numbers firstly,
Absolutely.
number one. Number two, that was with the implantable devices. In implantable devices. So when I first talked of the wearable devices, then I talked of the patch, and then I talked of remote monitoring of the implanted devices. In the implanted devices, if you soup it up by doing remote monitoring, you will have much better detection of arrhythmias and other problems, device troubleshooting, etc. will be better, and they have shown less mortality, less of inappropriate shocks. And you are absolutely right that very huge 27% is so between 2% and 3% becomes a 50% reduction. 3% becoming 2% is a 50% reduction. So it is like that. So this is a constant criticism. You tell me the absolute numbers also.
So should all patients of say sinus bradycardia or possibly heart block and the heart rate of 45-50, they should all undergo long monitoring. Or patients who have some syncopal attacks for no reason, should all of them undergo this?
So judiciously, yes, because many of these patients with resting heart rate 40-45, which becomes like a class 2 indication for pacing, but if they have nighttime very slow pulse rate and even long pauses, if 3 seconds is considered a threshold, some of these patients even have pauses of 5 seconds, 7 seconds, and so those are dangerous levels. And at that level, you would rather give the patient a pacemaker than wait for an event to happen, because the first event may be the last event. Having said that, there are many of our patients, elderly patients with heart rates of 45, 40, and they've been going on for years. They don't get a pacemaker, and they remain stable. Sometimes the rate even increases. So therefore, doing the monitoring in these patients, maybe 3 days, 7 days, you will be much safer, both clinically safer and also medico-legally safer. Because आपने उसको लगा दिया तो और उसको कुछ नहीं हुआ, he says कि डॉक्टर ने unnecessarily मेरा, but अगर कुछ हो जाता है और आपने नहीं लगाया था, so then you are also liable. So these days even medico-legally, if the technology is available, then why did you not get my 7-day holter done? 7-day holter is I think 7-day patch, whatever you want to call it.
You must offer it.
You should offer it. You should offer it.
I just asked because in a routine OPD, I noted the heart rate was 45 and the ECG shows first degree heart block. I sent it to the cardiologist about routine monitoring and this monitoring, it does not be complete heart block.
Oh.
And in retrospect, then the patient said कि चक्कर आते थे, they have disappeared after pacemaker.
So this, all these things keep happening.
Sir, we are not finished.
Best for last. Best for last. Sir ने तो note down करके सारे points.
So, again a great talk by Dr. Rajiv Agarwal. He is not only a wonderful cardiologist, a great human being as well. Very modest. So, Dr. Rajiv, let us discuss a little about your case which you presented, the VT. Did it last for more than 30 seconds? If it lasts more than 30 seconds, this would be a sustained VT.
No, I think we already answered that. Yes, it was a sustained VT.
It was a sustained VT?
Yes.
And what did you do?
I talked to the patient, I expressed incredulity ki how are you talking to me? By the time he came to the hospital, the VT had reverted.
So,
it was in sinus rhythm. We told him to get admitted, he did not get admitted. He said, मैं तो घर जा रहा हूँ. But then 2 दिन बाद he came again in the emergency with VT, and this time he was convinced enough to get the ICU.
this is a serious case, not a laughable matter. Any VT.
And this was a person who had no money problems. In fact, there are several such patients who are quite happy to spend money on themselves, but extremely anxious.
So what was this patient?
In the past, I've had medical conferences with this family. One family member sitting in Canada, one in Australia, और ये जो अलकनंदा में बैठे हुए हैं, तो इनके बारे में conferencing हो रही है, and so on. So after that, we did the angioplasty. That was 1.5 years before this. And then he keeps coming. But then this day he says, I'm having this event, and he sends me the ECG. And I first I didn't believe it. He says, I also didn't believe it. I checked it with my son's watch, and it was the same. So therefore I assume, because this recording would be around 15 seconds, but I assume it lasted for good 5-10 minutes. But he survived. So this is the point I'm making, that every VT is not going to lead to cardiac arrest. There are so many patients, especially, so this is unusual. Younger patients
This is what
with
I was telling
normal
you.
structurally normal heart, we often see the patient having VT and is quite comfortable. But this kind of patient, we would have expected this to have led to cardiac arrest. It did not in this elderly obese gentleman. So this shows the variability of clinical response.
So, this wasn't a case of structural heart disease.
Of course.
This is what you're saying.
No.
This was a structural heart disease?
Sir, old MI.
Please elaborate. Yeah, old MI.
Old, वो तो मैंने दिखाया था ना.
So what did you do?
He's a 64-year-old with an MI. We had put a stent, ejection fraction 45%. He's about 20 kg overweight, and he's on the various drugs for that. And so then we convinced him finally to get an ICD implanted. And ICD implantation and some antiarrhythmic drugs, which included beta blockers and cordon, immunodrone. The patient has not had recurrence of VT. We are confident because even non-sustained VT will be recorded by the device. अब नहीं हो रहा उसको. However, we were quite apprehensive that once we have implanted the ICD, after that we will have to do 3D mapping and RF ablation of the scar VT, because usually this would be a scar VT. There is a myocardial scar because of the heart attack. At the edges of it, there is a normal circulation of current. And so then you do 3D mapping, you isolate that arrhythmogenic area, electrically isolate it by doing multiple burns, and then you, so some patients even after ICD, because of recurrent shocks, we have to do ablation. There is one patient who we had implanted an ICD 5 years ago, and for at that time the patient had gone to the echo lab and collapsed there and was found to have VT. So then ICD is implanted. Next 3 years patient has nothing. After that he has recurrent VT. He is ablated. We first did sympathetic ganglionectomy because of incessant VT. Even that didn't work. Then 3 episodes of RF ablation for the scar VT. And now for the last 6 months the patient has no event. So not everything is just you make a diagnosis, you do this one and done. There are many patients who need continued attention.
So you elaborated a lot about this. I would probably tend to disagree a little here. Why? Because the pause sudden cardiac trial said you ablate first, then give ICD. See, it's not only that, even the SURF is a saline, it's a radio frequency ablation. See, this you need to treat VT here before you give an ICD. You need to ablate the scar because this patient had a structural heart disease. Please ablate the scar before you give an ICD. These are the recent papers. I thought what we did just the opposite. You gave an ICD first and then ablated. So talk us about this.
We have done both kinds of procedures, and this was discussed with the patient. He was not willing for the ablation at that time, and we did the ICD. We said, okay, we'll do your ICD. उसके बाद ablation करेंगे, उसके बाद लेकिन उसको.
Sir, recent European Society of Cardiology talked just last year also talked about the preventive VT. See, which was, this trial was presented in the recent ESC, and it said that catheter ablation is very successful in patients who have ischemic cardiomyopathy. So this has to be done first before you give a CRT.
70 to 80% success.
Yeah.
So we have to deploy both the technologies, and to an extent we have to take the patient's preference also into mind. They have multiple medical advisors also. I remember one patient, so contrary to what you were saying, I remember one patient. So this chap, he has this ischemic VT, and I tell him कि तुम आ जाओ and मैं पहले तुम्हारा RF ablation करूँगा, उसके बाद तुम्हें ICD लगाऊँ, because that RF ablation is not 100%. So this patient doesn't get it done. He goes to Cmes. Now we all know the literature, but since the patient has refused the RF ablation, Cmes वाले डॉक्टर ने उसको ICD लगा दिया. गाजियाबाद का मेरा पेशेंट था, Cmes में ICD लगवा लिया उसको. और उसके बाद जो भी रहा मतलब उसके बाद he got lost to follow. But what I'm saying is that you are very right, and I respect the scholarship in terms of what you read. But in practical terms, we do whatever is feasible. Sometimes with infrequent shocks. So this is also there. Sometimes with infrequent shocks, first shock, you can put an ICD. This patient did not have repeated shocks. If you have repeated shocks,
a shock if you do a ablation.
no, just say. This patient would be kind of 50-50. If the patient had recurrent shocks, then yes, the RF ablation would be definitely number one. In this patient, one could go either way. And I'm giving you my experience that in one patient where I had suggested the alternative route, and then he goes to the teaching institution. And there they see, okay, he's not willing for RF ablation, he thinks this is too hi-fi, so chalo ICD laga. So it all happens.
Okay, my last two questions will be regarding leadless pacemakers and leadless CRTs. Talk us about these two newer modalities, talking about the CSP, left bundle pacing as compared to the routine pacing that we do. Talk us about leadless pacemakers and the leadless CRTs, sir.
So leadless pacemaker, we have now the leadless pacemaker is dual chamber also, cost being like upward of 10 lakhs, just say, cost being high, so generally we will, so it's like a capsule just fitted into the right ventricle, and then it will give AV synchrony also now, using the an acoustic kind of a communication, so you can even get AV synchrony. Earlier the criticism was that it will be only a VVI pacemaker. Nowadays it will be, but it is 4 times the cost. So one definite indication is where there are access problems, or the patient has recurrent infection and therefore cannot get it. Otherwise, just that the patient does not want, and so therefore I tend to use it for the standard indications, not just for patient preference, because there are such patients who say I don't want a scar, ये तुमने अंदर लगा दिया कुछ नहीं पता लगेगा और पैसे की मुझे चिंता है, वो एक तो हो गया. Subcutaneous ICD is there. Subcutaneous ICD again where there are venous access problems. So this will be a lead which will be completely subcutaneous, and but it is a lead, so it is burrowed here all around the heart, and it will give the ICD function. So that is available from Boston. CRT and may the leadless variety. So there is some communication with Bluetooth technology, but this is still in the realm of mostly research. It is not prime time clinical. LBB pacing we are doing regularly in patients who have either an apprehension of progressive ventricular dysfunction, or there is LBB and then you put it across the septum, and sometimes you can normalize the QRS duration. It can be considered to be a poor man's CRT. You can use a dual chamber pacemaker and do the equivalent of a 3-lead pacemaker, that is a biventricular pacemaker. But still, it is not as effective as the normal 3-lead pacemaker. So now what they talk about is lot CRT, and in which the RV lead is screwed across. You still have a coronary sinus lead, and so you will get both functions.
Okay.
So all that is there.
My last question, sir.
Last 3 questions.
And my last question would be regarding, we know what PFI is, Dr. One. What is PFI? Physicians for India. What about PFA? Talk us about the PFA, sir.
पहले हम बता तो दो सर.
Pulse field ablation.
Yeah.
Or atrial fibrillation in place of the thermal ablation that Dr. Pollard does. Talk us about that.
So वो cryo ablation तो available है.
Pulse field ablation, sir.
Sorry,
Not cryo.
Sorry.
This is a pulse field ablation, different to the cryo ablation.
Right. So we have the usual RF ablation where we mostly do burn around the pulmonary vein orifices. Then you have cryoablation. Again, this will be done inside the inside the pulmonary vein orifice. It will be less traumatic. And third technology, which is the latest technology, also the pulse field ablation. Again, this is a newer technology, not something which I have done, but it is coming in.
It's as efficacious as your thermal ablation, but has probably more safety profile. You spare the esophagus, you spare the phrenic nerve, and you spare the pulmonary veins as well. Thank you, sir.
No question? Good. I think all of you would agree that we had a wonderful session. I would give it to Dr. M L Kalra sir to summarize this for us quickly. And I would like to say a million thanks to Dr. Rajiv Agarwal to do this CME for us. There are only 20 people left, but I think 20 people interested are much better than 60 people not interested. Thank you, Doctor. Thank you, Dr.
Before my esteemed ma'am, before you leave, madam, just listen to my last corollary.
Dr.
Yeah, my corollary, I want you to say.
You had a wonderful Diwali celebration. Now listen to what Dr. M L Kalra has to say.
My corollary to Dr. Tulsi and Dr. Rajiv, they were saying RFA.